this is the study from our own unit some years ago now, where we proposed the SAS score to predict outcomes for babies with Ebstein's anomaly and tricuspid valve dysplasia. So babies were given a score out of 10 based on 5 features, which were an increased cardiothoracic ratio, an increased right to left ventricular ratio, reduced or absent pulmonary valve flow, and retrograde ductal flow. And you can see from the chart on the left of the screen that all those babies that scored greater than 5 died, shown in the black, and all but one of the ones that had a score less than 5 survived, and the one who didn't survive actually had a good score to begin with, but as pregnancy advanced, things got much worse, and the baby didn't make it. So in addition to the factors that we looked at in that paper, several studies have now indicated that left ventricular myocardial performance is impaired in babies with severe tricuspid valve disease. I've highlighted 3 papers here, or 3 studies here, which you can look in more detail at your leisure. But the message from all of them is an indication for closer monitoring of left ventricular function, as non-survivors are more likely to have some impairment. Now, sometimes that's not always very evident to start with, but it could become more evident as pregnancy goes. The other important thing when we're seeing fetuses with this type of abnormality is to remember that this is a progressive type of lesion. And this is important because firstly, it makes it difficult when you see somebody in the second trimester to make predictions of outcome, as things can change. And it also can make the counselling of the families difficult because the early scan could be falsely reassuring, and we have to bring into the counselling that things can change as pregnancy advances. So in this study that I've highlighted here, they used some markers of poor outcome, which are sort of explained at the beginning of the results section here. And what they did was look at these markers at presentation and also in later pregnancy to see if they changed. So they had 51 fetuses of less than 24 weeks of gestation. And what they were able to observe was that you can have babies where there are no markers of poor hemodynamic status initially, but this can develop later. You can have antegrade pulmonary blood flow on the first echocardiogram, but you can develop pulmonary atresia later. You can develop new pulmonary valve regurgitation later with a sign of it earlier on. Left ventricular dysfunction might be present in the scans less than 24 weeks, but it's more likely to develop later. So continual monitoring is really important. And in most babies, we do see a gradual increase in the cardiothoracic ratio and the tricuspid valve annulus. So on the right of the screen here, there's 2 video clips. The first one that's playing now is from a fetus at 23 weeks of gestation. At this stage, there was mild tricuspid valve dysplasia. The heart is a little bit enlarged. There was a little bit of tricuspid regurgitation. But now the second clip here is the heart now is much bigger. It has progressed 10 weeks, so this is at 33 weeks. And you can see that nearly a wall-to-wall heart now, the tricuspid valve looks much worse, and there's a huge right atrium, and tricuspid regurgitation got much worse. So in addition to all the other things I've mentioned, the other thing that comes out as being important in terms of risk of death is pulmonary regurgitation. There's a multiple study of 243 cases highlighted here, and the study found that fetuses who had pulmonary regurgitation had only twice likely experienced fetal demise or neonatal death. And this is related to the development of a circular shunt, which is illustrated in this diagram. Having passed through a capillary bed, and then setting ebstein, this could cause systemic and low cardiac output when the vascular resistance falls. The pulmonary vascular resistance is already high in the fetus and will fall after birth. So in the fetus, the shunt may not cause systemic seal as such, but can lead to volume overload and heart failure. So because of this, treatment strategies have been advocated to limit ductal flow to try and improve outcomes. And these were described in the two studies I've highlighted here. There are other studies as well, but I've just picked these out. And this was one from the one on the left from a study for neonates showing that you can improve outcome by allowing the duct to close early. And the right is from advocated non-steroidal anti-inflammatory agents to restrict the duct to try and improve the outcome. Now, I don't have any experience of using this, so I hope nobody's going to ask me a question about that. So I just wanted to show you an example of how changing our management strategy has helped the tricuspid valve is normal. There was marked tricuspid regurgitation. There was fetal ascites, and there was pulmonary regurgitation in this baby, as shown on the right of the screen here. So from the fetal scans, we gave a very poor prognosis for this baby. We did not expect this baby to survive the early neonatal period. After birth, the strategy we adopted here was to allow the duct to shut. Years ago, it was automatic to start prostaglandins, but in this baby, we allowed the duct to start, shut, and nitrates were used to try and promote forward flow in the pulmonary artery. And this now is the same baby at 37 months of age. The baby's a lot older than that now, but these were clips at this age, and you can see that although not perfect, things are looking a lot better. Tricuspid valve, it doesn't look so bad. There is a little bit of tricuspid regurgitation. If I can get there we are. There's the tricuspid regurgitation, and we have forward flow in a normal pulmonary artery. If it will play, it will show you forward flow. We've got a little bit of PR, but a very good forward flow now. So this was not what we had predicted from the fetal scans, and this outcome has been much, much better than we had anticipated. So we do sometimes get nice prizes too. And finally, I think it's important that we all remember that we have to think about the whole baby and not just the heart. Although the incidence of genetic and extracardiac associations is low, the risk is not zero. And if these are present, these may influence the outcome of the baby. And on this slide, I've just sort of indicated some of the associations that have been described with Ebstein's anomaly and tricuspid valve dysplasia. Thank you very much for your attention.
Thank you. Thank you for very comprehensive reporting of fetal diagnosis I have some live questions. Justin, should I ask the questions now?
Yes, go ahead.
Okay, Gerlin, the first question is, how early can ebsteins be detected in utero?
Okay, so in our own unit, we have detected it from 14 weeks of pregnancy. And I think if you did the scans a little bit earlier, you probably could detect it. But certainly, we perform our scans from 14 weeks, and we have diagnosed ebsteins at 14 weeks.
Okay, second question, maybe you can clarify. The question is as follows. Is there any study of outcome of ebstein's babies or BT shunt or PDA stent in their first couples of weeks? Which procedure is better for ebstein's babies? Maybe you want to clarify the management of this very difficult group of babies in the first year of life.
I don't have that information. I can't answer that. I don't know. There might be other panelists who can answer that better than I could. So I think maybe that could be opened out to the panel.
Nicole, how would you manage neonatal ebsteins?
I fortunately don't have to manage them. I hand them over to my colleagues to manage. So those things are continually changing. And I think it depends on so many things. It depends on the severity. It depends on how symptomatic they are. I mean, even some of the ones we see from fetal life are not going to be symptomatic in the neonatal period and may not require to have anything done. It depends on whether they have flow in the right ventricular outflow tract. So there's actually many, many factors that are going to come into how we're going to manage it in the neonatal period, as you probably can add to yourself.
Well, in principle, what we would do at Great Ormond Street is that we would stop the prostin. We do not do BT shunts. We probably up the FiO2 or we use nitric oxide to drop the pulmonary vascular resistance to get the baby out of the neonatal period. And then we decide what to do next.
Yeah. I absolutely agree, and that was what I was implying with that last case that I used for demonstration, is that years ago we used to be giving prostaglandin and thinking of BT shunts, but that management has changed completely, and now the strategy is more to let the duct to close and to use nitric oxide and to try and bring the vascular resistance down and promote forward flow into the pulmonary artery.
Thank you. I got another question. How would you appreciate the value of Salem-Meyer index for prognostication of outcome?
I think it's a very good index. I think one of the problems with using it in fetal life is that things can change. So when you apply it to a scan in fetal life, you can say that is this is what you would predict from the scan at whatever stage you're doing it, but you have no idea how that's going to change in later pregnancy. And although, you know, some of the, when I quoted the other study, most of the babies that had good scores at the beginning stayed good, there is that potential for change. So you can't say to a parent that it's got a good score now, so it's going to be okay. You have to warn them that it can change during pregnancy.
Berlin, can I ask you?
Have I got time for one question? One final question. With the changes in our surgical strategy and the ICU management, does it change your counseling with the mothers?
Yes, of course it does. But I think what we're saying to not as other things too is we have to know what's going to happen after birth and what the outcomes are going to be after birth, because that's the information we have to convey to the family as well. So yes, we are constantly changing what we're saying to the families.
We have any, but Justin, I let have you continue.
Okay, I think Nico had a question before we moved on, and then we can move on to the next.
Yeah, just a brief question, a short question too. It was a fantastic talk. It's all from the audience. Counseling is very difficult, as you say, because it can be normal early in pregnancy. Are you aware of a difference between the tricuspid valve dysplasia and the ebstein in the progression of the disease? Or and in general, how do you counsel? You said it's difficult, but how do you counsel when you see an early ebstein or tricuspid valve dysplasia?
So it will depend on the severity of what you're seeing at the time. So if you see a wall-to-wall heart at 14 weeks or 20 weeks, then one would be quite negative in counselling. If you have one where the heart's just a little bit big and there's only a small amount of vessel regurgitation, you dysplasia seems to be more associated with extra cardiac things than ebsteins. So push much more strongly for invasive testing and things like that.
Okay, thank you very much. I think we proceed to the presentations. What follows now are 3 therapeutical talks. And before we do that, I think it's very nice to ask the audience a question on the moment of the disease. And I will show you a question, and with you there are 4 answers to be given. Please give the answer, and after the 3 talks, we repeat the question and see if there are any difference in your opinion. So this is the case. It's a 7-year-old asymptomatic boy with ebstein anomaly, and it's seen patient since the age of 2 years. He's a very active walker. He is New York Heart Association Class 1. There's a significant 2-centimeter apical displacement of the septal leaflet, moderate tricuspid regurg, RV dilatation, and a small ASD. During exercise test, he's 96 to 86. And over the past 2 year, MRI shows an increase of functional index RVA-DV from 120 milliliter per square meter to 130, and there is some decrease of LV volume 50 ml per square meter. So what would you do in this completely asymptomatic boy? Here are the 4 answers. Couple of it's for the answers to pop up, but we can see the results, and after we've seen the result, we probably start with the second presentation. And Victor and I are probably very curious of what your answer will be after the 3 talks, if you change your mind. So we have some time left. Heard from Justin that it takes about 3 minutes, the answer, so I think in the meantime, I start introducing someone who does not need any introduction. Joe Irani. He's leading persons in ebstein valve surgery. He's from the Mayo Clinics, congenital heart surgeon, and in this second talk, he will discuss about the cone surgery, whether it's ever too early to do a cone repair. And before we start the second talk of Joe, we are still waiting for the answer. It takes some time. In the meantime, a lot of questions pop up. Here are the answers. Okay, so cone repair is 41%, as you can see. Watchful waiting, 32%. Percutaneous ASD closure, 13%, and a cone plus a Glenn shunt in 13%. So the majority goes for cone repair, but there are also a lot of other answers. So I think it would be very interesting to hear what you say after the 3 talks. Joe, the floor is yours.
Oh, thank you, Nico and Victor, and thank you, Justin, for the invitation. I want to welcome the audience. It's very unique that we have physicians, surgeons, and patients and families on this presentation. So it's really a wonderful opportunity. So I have an interesting title. Is it ever too early? I do not have any disclosures. I think we'll begin with some facts to set the stage. First, there's about, at least in the United States, about 100 babies born with ebstein each year. Mortality is high, both with medical therapy and with surgical therapy, particularly if they're symptomatic. The average operations done at a center in this country each year is between 1 and 2. It can be considerably more than that. From the STS database, looking at results of neonatal surgery, I would draw your attention to this number. The mortality is almost 30%, and the composite morbidity mortality score is about 50%. And 3/4 of these babies had required ECMO. And this was a recent publication that we did 2 years ago. If you move beyond the neonate and into the infant, where the median age is going to be at about 6 months, the mortality is better, but it's still approximately 10%. And the composite morbidity mortality score is slightly better, but still actually not very good when you compare it to all of the other lesions that we deal with, even hypoplastic left heart syndrome. And if you get beyond infancy, the results look even considerably better, where the overall mortality is about 2%. And in experienced centers, and at least in our center, the mortality is now less than 0.5%. So what about the newborn, which is where I think most of the attention is directed here? I will first say that for the stable newborn, there is not a lot to talk, because any major interventions are generally not going to be necessary. It's going to be good critical and neonatal ICU care. But for the unstable patient, and I would say this is where the risk comes in. We heard a little bit about standard care with intubation, paralysis, nitric oxide, etc. And patients either have functional or anatomic pulmonary atresia. And if it's anatomic, the decision to do surgery is obvious. It's going to be necessary. But the functional pulmonary atresia patients are the ones that are the most challenging. If they have a normal left ventricular size with mild tricuspid regurgitation, they may need nothing with medical therapy, or if they do need something, it will be for persistent cyanosis, and it will typically be a shunt of some sort. If they have significant tricuspid regurgitation and cardiac failure, then, at least in our own practice, our preference is a biventricular repair, and we'll talk a little bit about which operation that should be. And I would say that these patients typically are not always very stable to begin with, but the real unstable patients are the ones that are the most challenging. And I think this is the patient where you need to decide whether you're doing a biventricular repair or whether you're going to go down a single ventricle pathway. And rarely would transplant be needed, and usually because there is a problem with the left ventricle at that time. From a diagnosis standpoint, that we heard a little bit about one index. I think in the newborn, many use the Great Ormond Street Index, which is essentially a ratio of the right atrium, the atrialized right ventricle, and the functional right ventricle to the left-sided structures. And basically, the larger the heart, the higher the mortality. So a very simple scoring system that can provide some risk statistics. Now, in the newborn over here on the left, you see that there's usually massive right atrial size, and there is usually dilated right ventricle. But I want to draw your attention to the fact that oftentimes there is septal leaflet present, in contrast to the older child on the right-hand side, where the anterior leaflet is typically very tethered, and sometimes there's no septal leaflet, which can make surgical management a bit more challenging. If we look at an important contribution from Dr. Sang's institution in the United Kingdom, MRI is being used more often, and typically, while it has been used to quantitate right ventricular dimensions and function, this is an article that addresses the the angle of the functional orifice relative to the AV groove in terms of a guide for the feasibility of cone procedure. And I want to draw your attention to the fact that these are in children 12 years of age. So not a practical option in a neonate or a very small infant. Now, the indications for surgery, certainly in the neonate, if they have anatomic pulmonary atresia, they're going to need an operation. But the other indications revolve around the presence of heart failure and failed medical therapy. And the bottom line here is that surgery is generally not elective. In contrast to children and older patients where symptoms may not even be present at all, and if they are present, it may be something minor like fatigue, but it's more objective information in terms of an abnormal exercise test or imaging documentation of progressive increase in right ventricular size, the onset of arrhythmias. Here, the bottom line is that surgery is almost surgical options. If we begin with the single ventricle pathway, which has been popularized by Dr. von Starnes, this is generally reserved for very critically unstable infants or newborns, mostly because the operation is very, very predictable and does not require a lot of expertise, where the biventricular repairs, I think, are more dependent on surgeon expertise. Now, Dr. De Silva, who is one of my mentors and taught me everything I know about the cone procedure, has certainly brought this into the armamentarium. But the question is its appropriateness in the newborn period. And then finally, Dr. Nachkreg, who I think has probably taught me everything I know about newborn surgery, has popularized the biventricular repair, who was also mentored by one of my previous mentors, Dr. Gordon Danielson. And the point I think about the Nachkreg approach is it's a monocusp approach, but it's non-leaflet surgery. It involves annular surgery where tissue tends to be a little more sturdy. And it also incorporates oftentimes this modified Sebening stitch, which is a maneuver to bring the papillary muscles down toward the septum that optimizes coaptation. So in my viewpoint, this is non-leaflet surgery in contrast to the cone procedure, which is mostly leaflet surgery. And these are the challenges in the newborn. First, the learning curve is actually quite difficult. And in my own personal experience, you can see in the first 80 patients, there was a 12 to 15% early reoperation rate because of dehiscence and recurrent tricuspid regurgitation. Obviously, once you get comfortable with the procedure, the early reoperation rate dwindles down to a relatively low level. The point here being that it's not an easy operation to do. The second thing is that bypass times and cross clamp times, while they are respectable for an elective operation, these can be quite long when you're talking about a critically unstable patient that would be having surgery in a non-elective manner. So a factor that likely should be considered when we're talking about a newborn. The other issue is in the newborn, there are episodes of pulmonary hypertension in the postoperative period. And these slides were provided to me as a courtesy from Dr. Chris Nachkreg, showing here that in the evening of surgery, we have oxygen saturations of 91%. This is in the little closure of the atrial septal defect. But you can see here by the second day, saturations are down to 65%, representing an episode of a pulmonary hypertensive crisis, which gradually gets better. And by the third day, we're back up to 89%. And by the fifth day, we're up to 95%. And the reason that this is important is because with the cone procedure, it is mostly leaflet surgery with many suture lines, tissue that in the newborn, in my opinion, is very, very fragile and delicate and vulnerable to dehiscence, particularly when you throw in pulmonary hypertensive crises. So from a results standpoint, our experience is really quite extensive at this juncture. We are now over 1,400 patients, and My personal cone experience up to the first of this month was 398, and the early mortality is very low, less than 1%. Dr. De Silva also has excellent results in his first 100 patients. The early mortality was similarly low, 3%. Again, the overwhelming majority of these patients are children and young adults. They are not newborns. This is the only paper actually in the literature that has the word ebstein anomaly and cone and neonate in the title. And they indicate here that 2 patients had ebstein anomaly with a biventricular repair, although here it says one had a Starnes operation, 1 patient died, and the other patient needed a reoperation. So I'm not really sure that this would be a position that would argue for neonatal cone repair. If we look at the results of a standard biventricular repair provided by Dr. Nachreg, you can see that the early survival in his hands is really quite good at 90%, not quite as good when you have pulmonary atresia. But the point here that if you can get beyond the neonatal period, the results are really good. So to summarize here, the considerations and issues with the cone procedure, in my opinion, are in the neonate, the learning curve is difficult. You're dealing with pulmonary hypertensive crises. Tissue is very fragile and vulnerable to dehiscence. And whether you choose a single ventricle or a biventricular pathway, if you do it properly, you really do not burn a bridge for doing a cone procedure further down the road. So, at least in my opinion and in my experience, I think the ideal time for it is between 3 and 5 years of age, assuming they have severe tricuspid regurgitation. This allows an EP study to be performed, which most electrophysiologists prefer to do by around 4 years of age if needed. If surgery is needed during infancy, it would be preferable to do it beyond 3 months of age, as it gives you the option of a bidirectional Glenn if necessary. And I think finally, even in the most experienced hands, I think it really should rarely be performed in a neonate for all the reasons that we just described. So thank you for your attention, and thank you for the invitation to participate in this wonderful webinar.
Thank you very much, Dr. Dayani. There are several questions from the audience, and one of the questions that pops up all the time is that's the preoperative management, like when you start prostaglandin and when do you stop it. What is your opinion on that?
Well, I think the first thing, after birth is to stabilize the child as quickly as possible with intubation and mechanical ventilation, start prostaglandin. And I think once the situation seems to be under control, I think at that point you would turn the prostaglandin off and see which direction things are going to go. And, at that point, you're going to have a better idea of whether you're dealing with anatomic or functional pulmonary atresia. If the patient is the baby's very unstable, the first intervention may be ligation of the main pulmonary artery to eliminate this circular shunt. And then you decide. The question earlier about ductal stent versus BT shunt, I think this is an institutional preference. I mean, whatever your team is most comfortable doing is the pathway that one should go, and that refers to both the interventional cardiologist as well as the surgical team.
And thank you very much. And there's another question from the audience. What are the most common complications of the cone repair? You mentioned the dehiscence. Are there other things you want to?
Well, I think that it was alluded to with Gerline's presentation, is that every heart is a bit different. So while we try to adhere to general principles and try to do steps of the procedure that you can do over and over again and keep it the same, we adhere to that. But the challenge is that everyone is a little bit different. So there's always these sort of modifications, that are going on. And typically, at least in my practice, the repair involves not only the cone repair of the tricuspid valve, but it involves plication of the HLI's right ventricle. It involves reduction atrioplasty. The common complications with all this could be block, particularly for surgeons that are not used to doing it. It's very, very easy to injure the conduction tissue. The right coronary artery can easily be kinked or compromised with the plication or with annular reduction maneuvers. Those would be the most important, devastating complications. And then, of course, dehiscence. And every surgeon that's done this operation, if they've done it enough, I am certain that they've had something fall apart and have needed to go back. And we emphasize a sort of a belt and suspenders technique to try to avoid this, but it's a balance because tissue is very thin and delicate, and it's despite a concerted effort, you can still have some aspect of the repair dehisce. So those would be the three things that I would say.
Okay, thank you. What does your decision to perform a Glenn shunt in this older in the infancy population? What is your decision making on that?
Yeah, generally speaking, it usually centers around severe right ventricular enlargement or severe right ventricular dysfunction. Would be the most common reason to do a bidirectional Glenn shunt. And in our own practice now, it's in about 15% of patients that we do it. Rarely do we need to do it in an older patient or an adult. And when we do, it's usually because there's profound right ventricular dysfunction and the operation may be viewed as an alternative or a bridge to transplant. But a subtotal closure of the atrial septal defect can be quite helpful, but it really does not unload the right ventricle if you have a very big, poorly functioning right ventricle. And so to avoid that low cardiac output syndrome, the bidirectional cable pulmonary shunt does two things. It decompresses the right ventricle, and it guarantees a proper amount of preload to the left ventricle, where the fenestration will provide some preload, but it does not decompress the right ventricle, which is really critical when you have a really big, poorly functioning, baggy right ventricle.
Okay, thank you very much. There are several questions from the audience. I think some of them we can cover at the end after all the talks on centralization of care and those type of questions. I give the word back to Victor for the next presentation. Thank you very much, Dr. Dirani.
Thank you.
Thank you, Joe. What a masterful lecture. I learned a lot from you guys. And the next, Dr. Da Silva reported the first cone operation back in 2007. And he's going to talk to us about why don't I do my operation? Are there new ideas for these symptomatic neonates? Dr. Da Silva. Justin, can you find Dr. Da Silva?
Dr. Silva, can you unmute?
I just did it. Can you hear me? Okay.
Yes, we can hear you, and you should be able to take control of the slides.
Okay, thank you. Thank you very much for the invitation to participate in this great event and such a nice surgeon and cardiologist. The only thing I cannot move it.
Can you click on the slide?
Yeah. Okay, where's my here? Nice. Okay, thank you. So the cone technique can be applied to nearly all types of ebstein anomaly. However, you have to remember the ebstein malformation affects the trachea valve and also the right ventricle. Therefore, an excellent trachea valve repair does not mean always a good clinical outcome. The main surgical challenge in the anomaly repair are tricast valve rotated into the RVOT and severe damage to the right ventricular structure. Here we have a 40 years old lady who had symptoms related to bad coaptation between the septal leaflet, the anterior leaflet, and the inferior leaflet. But she had a very good structure for the right ventricle. We did the cone here. You can see the operation complete, and looks very good. And the echocardiogram postoperative showed that the RV is very good, and the tricast valve open closed nicely, and there's minimal regurgitation. So this is excellent clinical outcome, anatomic and clinical outcome, of course. This is another patient that was this was 10 years ago. She's 10 years old girl, very cyanotic. She was referred to me for heart transplant in 2005. And I have so many cases like this with big heart. But you can see here that the left ventricle contracts reasonably well. And she had mobile anterior leaflet and papillary muscle here. And you can see some thinning in the apex, thinning in the outflow tract. So we did the operation, and this is the radiographic progress of her. Only 10 days after the operation, she was much better because we did the resection on the right ventricle. And after 4 years, the heart became almost normal, except we had a pacemaker because of sinus node dysfunction. The tricast valve repair in ebstein normally has some limitation, like valve that has leaflet displacement, the RV apex, or those anterior rotated into the RVOT, are generally not suitable for the traditional monocast repair. But they usually can be done with the cone technique. So we have here in the left modified four-chamber view showing you can barely see the tricast valve. We have a bare septum here and shifted to the right. And this girl had already a Glenn procedure. And you see in the middle that the valve opened toward the RVOT, very near the pulmonary valve. In this angiogram, show that the RG functional chambers is small and have significant regurgitation of the tricast valve. So we operate on her, and here you can see the middle that the tricast valve in the cross section is far from the pulmonary valve. The RV is still not perfect, and the tail of the valve, you can see a good functional tricast valve with minimal regurgitation. This is a case that made me worried because the initial echocardiogram shows that the right chamber were dilated, and there's some like awkward beating of the left ventricle. So we thought about adding a possibility of adding a Glenn procedure. So we did a heart catheterization study. Here in the middle, you see that the right ventricle has some dysfunction, but not too bad, and it has a large lateralized right ventricle. But most importantly, in the right, you can see that the right coronary artery was very dominant, and it was responsible for irrigating, perfusing the right ventricle and part of the left ventricle. We did the operation. I did twice. So I did the operation, she would not come off pump well. So we decided to place her on ECMO and to the cath lab to check for the coronary arteries. So here you can see a dysfunction of the left ventricle, a very small left coronary artery giving only the LAD in diagonal. And in the right, you can see that the right coronary artery was not kinked because I did, instead of doing a single plication that allows IV and also a single plication of the annulus better, we did multiple plication of the annulus. Preventing kinking on the right coronary artery was very important in this case. So the coronary artery is not stretched anymore. Next day, we were able to remove her from ECMO. And on the left, you see that the discharge echo showing good function of both ventricle and a good function for the tricuspid valve. This was difficult because of double orifice tricuspid valve. And here in the right, you can see that the fenestrated atrial closure shows shunt from the left to the right, indicating a good function for the right ventricle. And the X-ray showed that 2 days after the operation, the heart was significantly decreased in size. We have operated 32 patients since 2006 in the OPM Children's Hospital of Pittsburgh, and we did the cone repair in 26 of them. The median age was 12 years, and ranging from 5 months to 49 years. And we have to reoperate one patient, one tricuspid valve replacement, a year after the operation. This was disgusting to me because in about 300 cases that I had on the cone, the first time I replaced the valve postoperatively, and we programmed to replace a valve in one older patient. We did also neonatal cone in 2 patients and neonatal Starnes operation 4 patients. We did cone repair after the Starnes operation procedure in 3 patients, all of them with tricuspid atresia. We didn't have any mortality in those years here in Pittsburgh. In my experience, actually, I have 3% mortality, that the runner has said. In the beginning, because I was in difficult case and I didn't know the operation as well as I know now. But the last, since 2012, 2007, 12, 8 years without any death except for newborns. So the results are getting better overall with the cone experience hands, as Dr. Rand said. But the contraindication for the operation would be left ventricular dysfunction. And symptomatic neonates require complex cone repair and unstable. And in some few cases of pulmonary hypertension due to lung problem in older patients that might undergo replacement if it's easier. In newborn, very unstable, we prefer to do the Starnes procedure, which consists in excluding the right ventricle, with decompress the left ventricle, and then place a BT shunt to perfuse the lungs. But the Starnes procedure is effective and safe and early palliative treatment of the neonatal cardiogenic shock. But bear in mind that the right ventricle, as published already, undergoes progressive involution after the Starnes procedure. We thought that at a point of this reverse remodeling process, the right ventricle might be suitable for a pump in the biventricular repair, which could potentially provide more benefit than the single ventricle pathway strategy. So we did around 3 cases in here, and here you see removing the patch to see the valve under and the final repair. We did some treatment to the pulmonary valve in case of atresia that was before those underwent valvotomy. And then in the final operation, we recovered that valve patch in the anterior leaf at the pulmonary valve. Here's the echocardiogram of a patient. On the left, have this and regurgitation, the trachea valve, and here in the middle is after the Starn procedure. You see the patch with the fenestration, and finally after the cone, you see the trachea valve, and you see the pulmonary valve in the same projection, and both of them are functionally and anatomically very good. So we summarize that the cone operation is viable alternative for repairing ebstein anomaly after initial neonatal Starn procedure. We envision that the efficacy of the neonatal Starn procedure and the feasibility of the RV rehabilitation after the procedure favor this staged repair operation over primary to ventricle repair in critical newborn with ebstein anomaly. Thank you.
Thank you, Dr. Da Silva. Thank you for a very, very informative talk. Just wonder if there's any question from the panel. Joe, do you have any question for Dr. Da Silva?
No, he's given, as usual, a wonderful presentation. I would say that that for surgeons that may be listening, there is a role for whether it's a cone procedure or basically conversion from a single ventricle to a biventricular pathway, that at the time of the Starnes procedure, to not do anything to the tricuspid valve, just leave it alone, so that you have as leaflet tissue available in the future for consideration of being taken down. That would be, that would be the only technical point that that I would make. That the leaflets will be adherent to the patch, but if you remove redundant leaflet tissue, that may be more detrimental than just leaving it well enough alone.
Thank you, Joe. Dr. Da Silva, at what age you would do the cone after the Starnes?
Well, we have recently in Brazil, we did a case where we had a circular shunt that was put in the uterus.
We didn't hear you, Dr. Da Silva.
Recently, I did a case in Brazil where I had circular shunt, and then they prepared the kind of, like Joe said, they prepared the case during the Starnes procedure for an extra operation. They, instead of ligating the pulmonary artery, they put a patch inside the pulmonary artery. And then I did the operation at 5 months when the baby started to have cyanosis, and I did a direct cone repair. But in the other case, we did first. In another case, I did a 5 months a direct cone repair too, because there's contraindication for the gland repair. So, but like in pulmonary atresia, we prefer to do the gland first and then the cone, and that can be usually 6 months after the gland, but we don't know for sure. The first case we did on the baby was 1.7 years of age, 70 months of age. So it can be variable. If we can do initially, we can do, if you feel the right ventricle is good, and the valve is not very complicated, you can do the direct cone repair at like 5 months. And then after the cone, after the gland, you can do about 6 months of the gland. And during the gland, you can maybe approach the pulmonary valve and pulmonary artery and try to prepare for a repair in the future. Make sure you don't cause a great regurgitation on the tragus valve.
Victor, could I make one additional comment?
Of course.
You know, one of the things that we haven't talked about is fetal surgery for Ebstein anomaly. And we are in the final phase of completing a protocol where we would apply a fetal operation where the objective is to do an aggressive right atrial reduction prior to birth to allow, you know, whatever development of the lungs can be optimized so that, you know, the neonatal period perhaps may be not as unstable, and it could be viewed as a maneuver to maybe avoid surgery in the newborn period, which, as we've seen, you know, in numerous reports, is where all the mortality rests, is surgery in the newborn period, almost regardless of what operation you're doing. So, you know, we're getting to a point where we're going to be proceeding, you know, with an internal, you know, protocol to do this in selected patients that have really very, very large cardiomegaly, to try to see whether this will stabilize the newborn period in a more predictable manner.
Well, Joe, I wish you all the best, but may I turn your comment around? And the question is, how would you determine in neonatal Ebstein the lungs are good enough for a repair or for any surgery?
Yeah, we have a maybe one of our imaging cardiologists on the you know, on this webinar could comment, but there is an MRI. I don't know if it's a protocol, but there is a way to determine by MRI whether there is enough functional lung to be present after there would be aggressive, you know, cardiac reduction maneuvers during the course of surgery. So I think, you know, probably one of the more important things is how stable the baby is from a pulmonary standpoint after birth. I mean, you know, for many of these babies, we actually deliver them in one of the cardiac ORs, and then the child just gets intubated and gets immediately moved to, you know, next door to one of the other cardiac ORs to, you know, begin whatever procedure you're going to proceed with. But if the baby cries, if you're able to oxygenate satisfactorily with intubation and mechanical ventilation, that oftentimes is probably the most important predictor that there's going to be enough lung function present.
Thank you so much. Justin, do we have time for any more questions?
If there's a question, we can definitely entertain that. Otherwise, we can move on to the next, because I think that the discussion will be very interesting following Yiling's talk.
Maybe just one question from the participants. If for Dr. Diarani and also Dr. Da Silva, is it possible for you to determine pre-cone whether a gland shunt is necessary or not? Can you use any parameters to guide you?
Well, I don't have a very good experience with the gland. Normally, I decided in the OR, if I come off pump, I leave first opening the atrial septum, and then I decide if the O2 saturation is not so good, then we add, or if the patient evolve with dysfunction, then we can add a gland. The other possibility, when you in a young patient, if you cannot repair well the valve, this is a good way to get around it instead of replacing the valve. But my concern about the gland is, first of all, it's not very natural to have a higher pressure in the superior cava. And then second is that the inferior cava is directed usually to the left ventricle, to the left lung, and that could cause the formation of arterial venous fistulas in the lung. And I have seen patients with the procedure intact septum and evolve with low O2 saturation because of those malformation in the lung. And so this is one of the concerns. So it's helpful, but it's not everything, and you have to use it, but it's hard to define when.
Joe, any comment?
Yeah, I agree. I mean, we try to avoid it. It's not, what God had intended from the beginning. But with that said, it is a life-saving maneuver. And when you have low cardiac output and you are struggling in the operating room with escalating doses of inotropes and metabolic acidosis, this is a life-saving maneuver, and it can get you out of that hole. Again, it's reserved, at least in our practice, for really advanced stages with marked cardiomegaly or profound right ventricular dysfunction. And again, usually there's some discussion about this being a delay or a bridge to transplant. So we're really talking about really advanced cases. So again, you try to avoid it, but it has a role. And I think it's really one of the reasons that early mortality has been reduced to very, very low levels, across centers and across the board. Because, and just one final thing, ebstein anomaly is a myopathy of the right ventricle. It is a cardiomyopathy of the right ventricle. And there are some out there that believe a bidirectional Glenn is an advantageous maneuver because it decreases the workload of this myopathic ventricle over the course of a lifetime. So there's a role for it, but I think in more experienced hands, it's needed much less so than early on in one's career.
One final surgical point, Joe. How much restriction you put on the proximal right PA to stop too high the pressure transmitting to the Glenn shunt?
Yeah. I haven't done that routinely, and maybe it's something that should be considered. I know that there has been. I will say that I've taken 2 bidirectional Glens down in my career because they've come back with retrograde pulsations. I will say that both of those patients lived at high altitude, and that probably contributed to it. Because of the elevated pulmonary vascular resistance. And it's always I'm always a little nervous about resorting to that, but these were extreme cases and we didn't really have another option. So, I'm doing it less and less. I've not sort of done a selective banding of the right pulmonary artery, but I think it's something that I would consider doing. I'd have to talk to you about how you've approached it, but again, I'm not doing it as often, so the need is going to be infrequent.
Thank you, Joe, again, and thank you, Dr. Da Silva. I pass it on to Nicole now.
Thank you very much, Victor. We continue with the third therapeutical talk. It's an interventional talk. It's by Dr. Yi Ling, who's an interventional cardiologist fellow from Toronto. I think she's already back in London, if I'm correct, but maybe she can answer that herself. She will talk about closing the ASD with a PFO in ebstein.
Thank you very much. Thank you for the very kind invitation and the opportunity to participate in today's webinar alongside the esteemed expert panel. I've been tasked on behalf of my trainer and mentor, Dr. Eric Horlick, to really discuss why not just close the PFO. In ebstein's, everything will be fine over the next 10 to 12 minutes. So I'd like to briefly outline the potential role of transcatheter closure of the atrial shunt before showing a case presentation of a patient who underwent just this at Toronto General before drawing some salient conclusions. As we've all heard throughout the course of this webinar already, we know that ebstein's is rare along the spectrum of congenital heart disease, constituting less than 1% of the total patient cohort we see. Out of the varied associated anomalies, the atrial septal defect and patent foramen ovale is seen in up to 90% of reported series, and therefore presents itself as quite a common potential therapeutic target that isn't often looked at in isolation in this patient cohort. We also know that the natural history of patients with ebstein's is very varied, ranging from the severely cyanotic neonate with massive cardiomegaly that we've already heard about, but also ranges to the other mild extreme of the spectrum in the asymptomatic adult who may not require any intervention throughout the course of their lifetime. With regards to the varied spectrum of disease and the various therapeutic options that range from merely surveillance to surgical and catheter interventions, all the way to the end of cardiac transplantation, I'd really like to focus on addressing the atrial shunt in the adult population, but also briefly touching on some pediatric data. If we look at the current guidelines for indications for intervention in patients with Ebstein's anomaly, we see that there is a very clear mandate for considering surgery in the adult population, typically when patients are symptomatic with at least more than moderate tricuspid regurgitation or evidence of deteriorating exercise capacity on cardiopulmonary exercise testing. This is fairly similar across the European guidelines promoted by the European Society of Cardiology, as well as the American AHA-ACC guidelines. However, if we then actually specifically look at the guidelines in terms of what they address for catheter-addressed intervention, this becomes far less prescriptive. If we look at the European guidelines, we can see that it suggests that in the case of evidence of paradoxical embolism, the isolated device closure of the ASD or PFO can be considered in Ebstein's, or if there is cyanosis where the arresting oxygen saturations are less than 90%, that again, isolated device closure could be considered but requires careful evaluation. This is in contrast to the American guidelines, where there is actually no mention for a clear role or scope of device closure of the atrial shunt. The Canadian guidelines published in 2009 are a little more alongside the European guidelines, where they recognize that an improvement in symptoms and exercise capacity can occur from isolated treatment with closure of the interatrial shunt, and therefore the percutaneous option may be offered to selected patients. Bearing these guidelines in mind, with the evidence-scant landscape of treating these complex and challenging patients, what indeed is then the role of catheter intervention in Ebstein's? I would like to put forth that, in the words of my mentor and trainer, Dr. Horlick, who you can now see ready to close the hole in his COVID-ready gear, that perhaps we should be considering closing the atrial shunt as a first, if not initial stage therapeutic maneuver, more commonly than we currently do in clinical practice. We know that there is clear precedent and evidence for effective defect closure in hypoxic states across a multitude of pathologies that include obstructive sleep apnea, right ventricular cardiomyopathy, and indeed right ventricular infarction. We see its role in treating platypnea orthodeoxia and also its specific role to play in the management of complex congenital heart disease, such as in pulmonary atresia patients with intact ventricular septums. In acquired heart disease arena, it has also had a role to play when there has been demonstrable preferential blood flow from the systemic venous return from the IVC or the SVC across patent foramen ovale due to a change in the atrial septal axis, for example, post-thoracic or abdominal surgery. As we all know, right to left atrial shunting is often part and parcel of the clinical spectrum in Ebstein's, and there are various factors to consider that contribute to this. The most obvious first factor is obviously the elevated right atrial pressures that often exceeds the left atrial pressure. That could be either secondary to significant tricuspid regurgitation and or the presence of significant right ventricular dysfunction. In addition, as already mentioned as part of the earlier Q&A, the Ebstein's pathology is pivotal in actually incorporating in understanding that it is a cardiomyopathy and that there is a myopathic process of both ventricles that results in decreased right ventricular compliance. There is also the issue of streaming, where in certain selected patients we have seen on various imaging modalities that tricuspid regurgitation can be directed towards the interatrial septum, therefore promoting the obligate right-to-left shunt. In this 4D MRI flow cine loop that I hope would play shortly, 4D flow by CMR is an emerging technique that may actually be of particular utility in allowing the direct visualization of flow patterns in the dynamic regurgitation jet to better understand the mechanistic implications of the right-to-left shunt in ebsteins. My apologies that the video loop isn't playing as planned. And obviously with the obligate right-to-left atrial shunt, this then brings cyanosis, which in and of itself reduces the arterial oxygen content and therefore aerobic capacity in the patient, and thereby leads to exercise intolerance and an increase in the physiological dead space. Bearing this in mind, how do we best select the patients for consideration of transcatheter closure of the atrial shunt? In trying to achieve atrial shunt closure, the benefits that we're trying to achieve is obviously to alleviate cyanosis, to prevent potential paradoxical emboli and its clinical sequelae, as well as to improve the exercise capacity. From our practice and previous published data, it would therefore be important to consider pertinent factors that include evidence of desaturation at rest or with exercise. Patients should indeed have no more than moderate tricuspid regurgitation, ideally, for being considered for ASD or PFO closure. And in the cases where tricuspid regurgitant jets are directed towards the atrial septum, there may be incremental benefits to considering shunt closure in these patients. Importantly, these patients should have normal right heart pressures, and in the absence of this perfect storm, closing the interatrial defect in patients could actually increase the risks and potentiate outcomes by increasing the right ventricular workload, resulting in increased tricuspid regurgitation. There may be evidence of systemic congestion if shunt closure is undertaken in inappropriate patients, and these patients may end up in a low cardiac output state. And for these reasons, transcatheter shunt closure, potentially in isolation, should be avoided in patients with severe tricuspid regurgitation or evidence of congestive cardiac failure. We know that the atrial shunt is implicated in the impaired exercise capacity in ebstein's patients. This is data from the Brompton Hospital in London, where they demonstrated quite elegantly that exercise capacity is reduced in paired data in adult ebstein patients. And it was documented that a lower peak VO2 was found in patients with atrial shunts. This then had clinical implications in terms of the fact that a lower peak VO2 was found to be predictive of the composite endpoint of death, non-elective hospitalization, and the need for subsequent surgical repair. In addition, data from Dr. Donaldson at the Mayo Clinic also reflected that the major factor contributing to exercise intolerance in patients with unrepaired Ebstein's anomaly is the presence and the size of the intracardiac right-to-left shunt. With this in mind, and despite recognizing the role that atrial shunts play in the symptomatology and clinical outcome of these patients, isolated ASD or PFO closure is still minimally undertaken. In this Mayo series published in 2008, out of 539 patients who subsequently underwent Ebstein's surgery, isolated closure of the atrial shunt was only undertaken in 7.6% of the patients prior to presenting to Mayo for consideration of surgery. And indeed, in their more contemporary report in 2018, only 1% of the cohort underwent transcatheter atrial shunt closure. Why is this the case when actually it is a technically feasible procedure? I'd like to present the results from Sick Kids, the Toronto series, where they undertook transcatheter closure of atrial septal defects in children with a hyperplastic right ventricle. In this series by Dr. Benson's group, atrial septal defect closure was considered in 17 children, out of which 6 had ebsteins. And these children were considered eligible for ASD closure if they had unobstructed flow to confluent pulmonary arteries, if they had resting oxygen saturations above 90%, and if there was no evidence of right heart failure. As part of the selection criteria for transcatheter intervention, these patients underwent test occlusion of the ASDs within the cardiac catheter laboratory for 15 minutes, and it was felt safe to proceed to ASD closure if there was no significant drop in systemic pressure, if patients didn't have a drop in their right atrial saturations, or there was no significant increase in the mean right atrial pressure exceeding 20% from baseline. Dr. Benson's group found that it was feasible to close ASD in all 17 patients, in which there was an immediate increase in saturations from 91 to 98%, and that there were no adverse hemodynamic changes with test occlusion of the ASD. At follow-up, none of these children had adverse clinical outcomes, with no deleterious changes to their right heart and no changes in severity of tricuspid regurgitation seen. If we then look at the other limited published data in the adult population, there have only been 3 other series to date, which specifically examined the role and the safety and feasibility of transcatheter ASD closure in ebsteins. It is worth noting that across these 3 publications, only a total of 22 patients underwent transcatheter ASD closure or PFO closure in isolation. I think highlighting one, the difficulties in identifying the right patient to undergo this procedure in isolation rather than going down the surgical route, but also the fact that this is an incredibly heterogeneous and rare condition of its own. What these 3 studies did show us, though, is that across the 22 patients, successful transcatheter closure was achieved in all patients, and over a follow-up period ranging from 1 to 5 years, there were no adverse either procedural or hemodynamic outcomes following transcatheter defect closure. These patients demonstrated improved oxygen saturations and improved exercise capacity. So I would like to purport that with the data that I've shown, that transcatheter ASD PFO closures have been shown to be well tolerated across the small series published to date, that there is relatively simple criteria as per Dr. Benson's paper for interventional decision-making with regards to safety and feasibility of closing the atrial septal defect or patent foramen ovale, that doing so achieves objective improvement in exercise capacity and oxygen saturations in these patients. And it also thereby mitigates the risk of paradoxical emboli. I think the pivotal point to make is that closing the atrial shunt in isolation doesn't actually close any doors with regards to further therapeutic options. It is a low-risk procedure. There is minimal morbidity associated with it. Patients have their PFOs closed as part of day case procedures and have a simple overnight stay for ASD closures in comparison to the complex morbidity that is associated with complex ebstein surgery that we've already heard about. Closure of the atrial defect in these patients is as per standard published guidelines, and certainly in Toronto, we adopt the stop flow balloon test occlusion technique for 15 minutes and monitor the hemodynamics and saturations carefully during these 15 minutes prior to successful deployment of an appropriately sized device. Before I finish my presentation, I'd like to just briefly outline a 36-year-old female with Ebstein's anomaly who underwent transcatheter closure of her atrial septal defect. In 1996, she had cryoablation of an accessory pathway on the background of pre-excited atrial fibrillation, and in 1999 had an embolic event with an inferior myocardial infarction where normal coronaries were demonstrated. At the time of her review, approximately 10 years ago, she was troubled by fatigue and no longer able to work, and had no recurrence of palpitations since her previous ablation in 1996. On examination, she was normotensive, mildly cynosed and clubbed, and there was evidence of a fixed split-second heart sound with a soft systolic murmur on cardiac auscultation. Her apical four-chamber echo image that you can see on the screen demonstrated a severely dilated right ventricle with a 3-centimeter apical displacement of the septal leaflet. There was moderate tricuspid regurgitation with estimated pulmonary pressures of 42, and this was in the context of a 2-centimeter secunda mitral septal defect with bidirectional shunting and normal pulmonary venous return. In view of her symptoms, she underwent exercise testing, and on a cycle ergometer, she exercised for 10.5 minutes, achieving 64% of her predicted peak VO2. Importantly, her baseline saturations of 94% dropped to 76% at peak exercise. And on the basis of her symptomatology and her exercise results, her case was presented at surgical conference for consideration of surgical intervention versus transcatheter intervention. I'm pleased to say that the vote was for catheter intervention on this instance, and here you can see her invasive hemodynamic data at the time of catheterization and test occlusion of the atrial septal defect. Importantly, she had normal right atrial pressures and pulmonary pressures, both at baseline and after test occlusion. And it was also quite satisfying to see that her resting saturations of 92% had fully normalized to a fully saturate 100% during the test occlusion. Following balloon sizing, a 26-millimeter defect was measured, for which she underwent a successful deployment of a 28-millimeter Amplatzer septal occluder, which was well tolerated. At her clinical follow-up, 6 months post-procedure, she was noted to be symptomatically much improved with much less breathlessness, and she was back to her busy life working as a florist. Her echo was unchanged except for a stable device position with no residual interatrial communication seen. And on repeat cardiopulmonary exercise testing, although there was no notable objective improvement in her peak VO2 achieved, she is no longer desaturate with exercise. So to conclude, I hope that I have been able to briefly demonstrate the safety and efficacy of a transcatheter approach and shown that it is technically simple and well tolerated in the appropriate patient cohort. I would suggest that perhaps patient selection for transcatheter intervention in ebstein's is actually the most challenging part of the actual process, and that it may be particularly well suited to patients without severe tricuspid regurgitation. Patients with exertional symptoms demonstrating right to left shunting would certainly benefit. And bearing in mind the conversations we've had during this webinar about the importance of surgical expertise to try and maximize surgical outcomes in what is very challenging surgery, that actually perhaps ASD or PFO closure is a less invasive, simpler option to consider, particularly in areas where patients are cared for without access to specialist surgical expertise. With careful screening, we would purport that the risk of acute decompensation is small, and that also then again allows future surgical and transplant options for the selected patient. Certainly, as with most things in ebstein's and congenital heart disease, it is an evidence-scarce zone, and therefore case selection and the criteria for doing so merits prospective study and further refinement, which is challenging of its own accord. Thank you for your attention.
Thank you very much, Yuling, for this excellent talk, and it was quite challenging for you, I think, after 2 surgical talks to come with to finish with an interventional talk on a even some bit controversial topic. In literature, there's not so much reported on the ASD closure, as you mentioned in your talk. So who would be the ideal candidates for you to preventively use this technique to prevent embolisms, or is there an indication to do it preventively?
I think that's probably a slightly contentious issue to think about, and I'm sure different centers will have different closure. I think if a patient's had an embolic event in the absence of other exertional symptoms and appropriate suitable anatomy for it, with no more than moderate tricuspid regurgitation, reasonable right ventricular function, and no evidence of congestion or cardiac failure, then these would be ideal patients. The younger adult patient cohort would also be good initial target cohorts to look at, as it certainly then doesn't preclude them from further interventions later on in their adult trajectory.
There's a question from the audience on the right ventricle being myopathic and maybe the function worsens in the future. Is it then a good idea to close the ASD or see RV decomposition earlier?
So I think
although you measure, of course, you do your measurements at the time of implant.
So we certainly do measurements at the time of implant. I'm under no illusion that a 15-minute test occlusion is necessarily representative of what the patient's myopathic right heart is actually like in day-to-day life with different activity levels. But it does at least present a baseline surrogate for any immediate red flags that would otherwise appear. Whether or not it necessarily worsens outcomes or speeds up the trajectory to further intervention, I don't think is the question we know the answer to at the moment. I would certainly be very interested to hear other views if there is evidence that suggests otherwise. And really, because it's such a simple intervention, if patients then come to surgery thereafter but have improved quality of life and symptomatic improvement in the interim, it is, I think, still an avenue that's worth pursuing for that reason.
So Nico, I'd like to throw a few thoughts out there for people to consider. First, I think Ailing has given a wonderful presentation, but there are a couple nuances that I think really deserve comment. The first is the assessment of tricuspid regurgitation and experience, and I think in my cardiology colleagues would attest to this. The most common mistake with the analysis of Ebstein anomaly is underestimating the degree of tricuspid regurgitation. And this case presentation that you gave before this series started of a patient that has, quote, moderate tricuspid regurgitation, and then you show subsequent imaging studies that shows that the right ventricle is getting bigger and bigger, that's not moderate tricuspid regurgitation. That's severe tricuspid regurgitation that is not appreciated. And I think in this example that Ealing showed it, where it was, quote, moderate tricuspid regurgitation, that right ventricle was huge and the ventricular septum was displaced toward the left ventricle. And I would argue that in that patient, we're underestimating the degree of tricuspid regurgitation, because mild to moderate or moderate tricuspid regurgitation, at least in our experience, does not cause profound right ventricular dilation. And I think that's really the key thing that needs to be ascertained, because when I look, we talked about bidirectional Glens. A number of the patients I've done bidirectional Glens on are patients that had ASDs closed elsewhere percutaneously, and the right ventricle now is big and it's dilated and it's even more poorly functioning. So while it's a simple procedure, if it's done in the wrong patient, I think there are some penalties that that we will pay down the road. And I think the understanding of the degree of tricuspid regurgitation from the very beginning is really a critical piece of information that needs to be ascertained, because in many ways, the ideal patient for ASD closure is somebody that doesn't need tricuspid valve surgery. And I would say that in the spectrum of Ebstein anomaly, that's probably the exception rather than the rule. So I would just say that keep that in mind, because I think it's an important variable that factors into the decision making.
Thank you very much, Joe. I think that is a nice timing then to continue with the poll question.
Dr. De Silva wanted
Yes.
to chime
Oh,
in.
sorry, Dr. De Silva.
Yes, I would like to comment that, like Joe said, when they select very well, like she did, I think the result can be good, but then you need a good follow-up. I had a recent case which they did that. They resolved the issue with the saturation, but then the exercise tolerance didn't improve much, and she was in 62% of the normal exercise tolerance range. So then we did the COM procedure, and that changed everything. But so the selection has to be very careful, and also the follow-up. But might be useful in a little older who has some hypopulmonary resistance and relates some for low to saturation. So you can close the ASD if possible, of course, doing the test in the CAT lab, and then improving the O2 saturation can improve the myocardium. But then I recommend the operation. And in the other instance, I left the ASD and the patient was still cyanotic with a good function of the trachea valve and some dysfunction of the right ventricle. Then they closed the ASD that was not closing spontaneously. And then the patient improved overall by improving the O2 saturation. So this is another consideration too, that I think you should dedicate for those cases. Would be a great contribution to it. Okay, thank you.
Thank you, Dr. Silva. I think also regarding the time, I think we proceed, and then we proceed with the repetition of the poll question. Can we show again the poll question on the treatment strategies and see how the audience thinks about the answers now? And in the meantime, maybe we can discuss a little bit more. The poll question is showing up. Same question. It's showing up yet. In the meantime, we're having an intervention list. Here it's coming. So again, this 7-year-old boy, asymptomatic, and with a bit of increase in the RV volume, a bit of decrease in the LV volume, but otherwise asymptomatic, a bit of desaturation during exercise, moderate TR. What would you do? Cone repair, watchful waiting, percutaneous ASD closure, or cone repair plus Glenn shunt, 1.5 ventricle repair. So while the audience are still voting, maybe a question to the interventionalists and the surgeons on doing a catheterization before the surgery, also because of cardiac output, but also because of deciding whether a Glenn shunt should be performed. Is it necessary or is it unnecessary?
I can throw a comment out there. I think most of the time it's not necessary. I think that in general, pulmonary artery pressures are usually normal with Ebstein. I think that if the echocardiogram suggests a high right ventricular systolic pressure, and you really think you're going to need to do a Glenn, then I would do a cardiac catheterization. I think in an older patient that has hypertension, or someone that you think may have left-sided abnormalities that would the permissibility of doing a bidirectional Glenn, I would do cardiac catheterization. But most of the time, I think you're able to do it, and I would reserve a hemodynamic cath for concerns raised on an echo or other factors that would make you worry.
Okay, thank you, Joe. I think we have now the answer on the treatment strategy I think the majority of the audience now goes for a cone repair first. There's still some percutaneous ASD closure. Congratulations, Yuling. You did a good job there. And watchful waiting is for 14% and 6% will do a 1.5 ventricle repair. So I think the majority answer is their favorite, and I think that is also something we learned from these 3 talks. Regarding the time, we continue. I give the word to Victor for the final speaker.
You're muted. I've asked you to unmute. Can you?
I'm so sorry. I'm going to the last speaker, Marina Hughes. She works at Dunn Street. And since the talk today is about how we can improve outcomes, Marina is going to tell us all. Marina, is your responsibility now. We need you, Marina.
No pressure, Victor. Thank you. I think I'm there. I'm on a screen will come.
Just click on the screen.
Okay. Done. Gone back one. Never mind. Thank you, Victor and Nico for moderating, and thank you to the Hart University for this opportunity to speak in the panel. It's truly an honour, but obviously a hard act to follow the life experience and the insights of the previous speakers. But I can give you a quick now and realistic, practical view of how MRI really does help us with all of the management and care of our patients with Ebstein anomaly. And we've discussed all the way through this panel that this is a developmental disorder of the tricuspid valve and the myocardium, the biventricular myocardium, with all the features listed here. And the panel shows 4 different patients, each born with different degrees of leaflet lamination, valve distortion, and cardiomyopathy. The top panel is a 40-year-old man, the lowest is a 4-year-old boy, and the lowest panel, the patient has no functional right ventricle visible in this 4-chamber view. But this patient does have an atrial communication and does have, has been palliated with a cava pulmonary shunt to improve left heart filling. But the slide really is just to illustrate again the infinite variety of morphology and importantly, physiology within the single diagnosis of Ebstein anomaly. And hopefully I will just continue on. Where is my page? And that's not forgetting the conduction anomalies and the abnormalities of the left ventricular myocardium that we've also discussed. And so with all the variations of valve and myocardium, there's an extensive range of presentation times and symptoms and problems. And this brings with it, as we've discussed as well, a large range of interventional options. And all of the interventions simply bring palliation of the hemodynamic status and not cure. And so with all this complexity, often the simplest outcome measure of survival is all that's possible, and certainly that's the case for neonatal presentations and from the neonatal perspective. But what is fascinating is that what was found or published in this echocardio paper 30 years ago from Great Ormond Street is that for older patients and children, well, for children and older patients, the prognostic implication of excessive right heart size combined with poor left ventricular filling are strong, but they're not the only indicators of risk. And so for the whole lifetime of each Ebstein patient, at many stages, there's constant weighing up of the risks and benefits and likelihoods of success. And this is essentially after the neonatal period and after some of the emergency procedures that need to be done very early in a patient's life when neonatal Ebsteins. So can MRI help us to carefully poise this balance but this is for the patients repeatedly, possibly at every stage for the whole of their life. And what we've got to remember is that this is a lesion affecting neonates and a lesion affecting a valve, and therefore MRI, as all the speakers in fact mentioned, MRI is not as helpful for the crucially ill neonate in the intensive care unit. This is really for post-neonatal survivors of that neonatal stage, but still echocardiography is first line, crucial for the diagnosis, crucial for the monitoring of the patient through and pre and post intervention. But with older patients, again, it's a complex lesion with multiple manifestations, and we need multi-assessment to give us the whole picture. And so electrophysiology, exercise testing, and CT imaging also play a huge part. And with that, in the current climate, particularly with restriction and resource implications, we have to carefully use the best aspects of each test so that we avoid duplication and we carefully integrate the data. So how specifically does MRI help within that whole decision toolkit that we've got? Does it give us parameters to predict other outcomes, or can we use MRI parameters themselves to predict outcomes? And for patients with a native Ebstein valve, there are many MRI parameters that have been shown to correlate with clinical risk and with exertional performance and symptoms. And many groups from many centres internationally are studying this. And these are just a few of the publications in the last 5 years. But the caveat for all of these studies for MRI is that they're mostly cross-sectional, they're single-centre studies, and they've got relatively small cohorts. And so MRI is useful, but for which patients and how? And we unconsciously factor all of these issues into our clinical decision to use this tool. But to simplify things, in fact, for any outcome, accurate diagnosis is critical. And conventional MRI images can be used to augment or refine the echo diagnosis when acoustic windows are difficult. The patients on the left all were diagnosed with Ebstein, but actually were found to have different lesions requiring different intervention. And the patients on the right were thought not to have Ebstein, but in fact, with morphological and closer analysis, these do. And that changes the options and changes the prognosis. So with patient cooperation and with regular cardiac rhythm, MRI can give a detailed 360-degree view of each valve leaflet and the biventricular morphology and function. And MRI will delineate, importantly, as we've heard, the left heart performance, the phenotype, the filling, and the function. And importantly, MRI can quantify the size of the right atrium, the atrialized right ventricle, and the functional right ventricle. Each component has important implications. And many teams have worked to find practical and reproducible methodology and correlated findings with relevant exercise, tests, biomarkers, and physiologic observations. But most have shown, and especially in younger patients, that clinical dysfunction does correlate with increasing right heart size and correlates with the right to left heart ratio of size. And how do we measure that size? Well, again, with conventional MRI at the moment, most units are using either short axis or transverse axis two-dimensional cines to create a three-dimensional volume assessment of the ventricle and the atria. And there are many automated tools, but for Ebstein, the images are manually contoured generally because automated techniques just do not reliably distinguish between the atrial and ventricular components. And with that, with manual segmentation, careful cross-referencing of the slice position is really important to help improve the accuracy. But all of this is very time-consuming and it can have important variability. So despite this volumetric caveat for MRI, in fact, MRI encapsulates truly the complex hemodynamics of the Ebstein phenomenon. And some of the proven key markers of outcome are the volume of pulmonary artery forward flow and the volume of or the proportion of tricuspid valve regurgitation of the right ventricular stroke volume, and the shunt dynamics across any atrial septal lesion, and characterize restrictive physiology, which we'll come to a bit more later. And novel methods are being tested and validated all the time against biomarkers and functional status. And so for the assessment of the ventricle and the valve, though, MRI is not the perfect decision tool. Image quality is often poor because of arrhythmia. All of the systolic function indices are load dependent and therefore heavily confounded by the tricuspid valve regurgitant volume or quantity. And so it's very difficult to predict the intrinsic right ventricular contractility and to guess what it might be with different loading post-intervention. And also added to all of that, or compounding that difficulty, is the relatively low temporal and spatial resolution of cardiac MRI, which limits the power to interrogate the rapidly moving and very thin wall right ventricle. But with regards to intervention, MRI techniques are very useful for giving a valuable comparative hemodynamic. And so the patient can act as a baseline for themselves. And MRI has provided an enormous amount of data to assess the cone reconstruction surgery, both prior to the valve surgery and assessing the hemodynamic outcome. And our group at Great Ormond Street, but also in Munich and Boston, have proven with MRI that the successful cone reconstruction improves forward flow through the pulmonary trunk and therefore improves left ventricular filling, and that correlates with exertional tolerance. So MRI here is providing outcome measures of a different intervention. But not all cone procedures result in measurable improvement of RV function, and many factors are potentially responsible for this. And also, despite elimination of the regurgitation and restoration of valve position, and just to demonstrate very high right heart filling pressures. And there are also a small number of patients where the cone valve reconstruction remained intact, but the annuloplasty dehisced, allowing torrential regurgitation around the cone valve. And so our group retrospectively analysed a whole surgical cohort at Great Ormond Street in an attempt to characterise the valve and the ventricular features that might predict some of these suboptimal or different outcomes. We actually searched for a single, reproducible, quantifiable measure because of the complexity of volumetric analysis. And we've shown that the rotation angle of the effective valve orifice may be a key measurable factor. It's the effective valve position, and this critically relies on the degree of mobility or the tethering of the anterior leaflet, which, as we've heard, is the major component of the reconstructed cone-shaped valve. And this principle, in fact, was elegantly described by Christian Schreiber in his analysis of morphologic specimens. It does also correlate with the Carpentier classification, and it can be interrogated with echocardiography using an oblique subcostal view if the acoustic windows permit. And in our cohort, it was the greater rotation of the ebstein valve. Those patients were more likely to suffer dehiscence if there wasn't adequate patching to reduce the tension on the surgical repair. And paradoxically, these patients with the least successful surgeries tended to be the patients who would classically have been described as less severe tricuspid regurgitation or less severe ebstein because they had less right heart dilatation. But here, I think we can contribute to the discussion on closure of an atrial septal defect. What comes to light with this is that there is a whole additional spectrum of ebstein anomaly with dominant ventricular and valvar fibrosis. This is associated with decreased RV myocardial compliance and restrictive hemodynamics. And in these patients, there are significant symptoms They have exercise tolerance, exercise limitation. They have frequent atrial arrhythmias. They also have cyanosis because of the high pressures on the right. But they do have less right heart dilatation and less tricuspid regurgitation. So they don't fit the traditional risk profile, but I would really hesitate to completely obstruct the atrial communication in these patients because of the risk of high systemic venous pressures in that kind of anatomy. So, in fact, each patient's ebstein malformation must be individually characterized for optimal surgical planning, and there must be really close communication with the surgical and the interventional team and looking at the whole hemodynamic. So, this have shown, to mention this as well, we were talking about the need for cavo-pulmonary shunt or predicting, and very interestingly, just the rotation angle in our cohort was a very strong predictor for the need for cavo-pulmonary supplementation of left ventricular filling. And so just that angle, which could be measured with MRI or cone, but we sort of validated it with MRI, can be a useful non-invasive predictor in younger patients. So many centres have shown that MRI can be used to predict outcomes, and it can be used as an outcome measure. But all the data, as I've mentioned, is retrospective, limited to small samples from single institutions. Almost all of it is static, no good data of imaging during exertion stress. And there's a heavy selection bias because we only actually see the symptomatic or referred patients. And all of the quantification is error prone, as I've mentioned. But I do think that we can conclude that MRI does add some critical and unique data to the ebstein decision toolkit. Echo, of course, is first-line imaging, but integrating all the data, particularly electrophysiology and exertional data, is crucial. But we've got a lot to learn, and we've only got probably 0 negative minutes, but I'm going to leave you with 2 image shapes with our aim for knowledge in these areas. And definitely for MRI, we need to work together. We really need multi-institutional data. And we also need to examine all ebstein patients, including asymptomatic ones, to learn how their hearts work. But we need to drill this down so that each ebstein patient has a personal hemodynamic profile to help us plan the interventions and modify the risks. But most importantly, and it's been mentioned, but the MRI data is very, very poor in this area, we need to examine patients that survive neonatal life longitudinally for the whole of their lifetime, regularly, systematically, before and after any intervention. And that way we'll learn about the hemodynamic remodeling and the progress of the lesion. And so I call for this, and let's talk about it. Let's work together. Let's keep learning. And thank you again to the Hart University team, but thank you especially to my excellent and very skilled Great Ormond Street team. Thank you.
Thank you, Marina. Thank you so much. Is there any question from the panels? Hi, Dr. Da Silva.
Yes. I first I want to congratulate you and Dr. Molina and your group for this excellent presentation. It shows very good images of the anatomy of ebstein anomaly. One thing that I would ask you is if I have divided the patient by age group. For example, I think when you have those tethering in the anterior wall, you have like the leaflet is directly attached to the endocardium. So you say linear attachment. In those cases, surgically, in order to get a good valve, you have to mobilize a lot. And when you're doing older patients, this wall of the right ventricle is thin. And then if you cut it, you mobilize the valve, then that area tends to balloon And so this is a problem, and we do later. So when you do young, you have a better experience with this. And I don't know, but I know the surgeon have to do more in the right ventricle to prevent that to have that ballooning phenomenon to happen after the operation. And my question is, have you noticed that is younger patients do better when you do it at a younger age? Because I think overall we had to do at a younger age.
Is that a question for me?
Yes, the question is if you have notes and difference.
Yeah, we are looking at that. Anecdotally, we have noticed that potentially earlier is better, with the caveat that too early, very, very young neonatal. We haven't yet brought that data together and been able to prove it. And obviously, like most things with congenital, we don't have a control. We don't have any way to prove this. But I know Victor may have a comment on this, but certainly we feel that with the right, I think it's mostly the valve attributes. With the right valve attributes, we will have the better outcomes with earlier surgery prior to the significant dilatation and the hemodynamic changes that occur with chronic massive regurgitation.
May I just add a comment about what Marina said? It is a sort of philosophy, because the cone valve, as you know well, is a living valve. I think with a reasonably competent repair, we know the valve would have a long durability. And we also believe in one thing, the competent valve is almost like a drive for the heart muscle to perform. It's like sending the right heart a message to do the work appropriately, and we have data to confirm that. And it's almost like the thinking, the form follows the function. And but we need a lot more data to confirm that, and we need the time as well.
Yeah, what I have seen that when you wait too much, even the outflow tract of the right ventricle starts to dilate. And then when you go to the operation, you don't have the whole ventricle with a very thin wall. So when you go earlier, at least that area of the ventricle will work more appropriately. Because I think the attachment of the valve prevents the ventricle from dilating. So sometimes you have a bad valve and the ventricle didn't dilate accordingly, I would say. And that's the reason, because that's anatomy. But and the way to solve that is to do an earlier operation before you start dilating the outflow tract of the right ventricle.
Joe, do you want to comment on that?
Yeah, I actually agree with what Dr. De Silva said. And one of the first, that was a wonderful MRI presentation. And we obviously have a lot to learn from MRI, and we're trying to do it in most all of our patients now. I mean, it can be a challenge. There's a cost issue. If the child is small, it requires general anesthesia if you want to get good images. So there are some variables that can make it difficult to get in everyone, but we really do need to get it in everyone as often as possible before and after, so we understand what happens to the systolic function of the ventricle. We still don't know to this day whether or not the ejection fraction actually really gets better with Ebstein surgery. I mean, we know the heart gets smaller over time, and we know that the stroke volume is going to improve depending upon where you re-anchor the valve. We've learned a lot, but there's still more to learn. But one of the things that I would say, when we open up the chest and we look at the heart before we start, I can tell right away which heart is going to limp off bypass. And what I do is I look to see whether the anterior wall and the infundibulum, which is what Dr. De Silva is talking about, collapses in diastole. If you get a little bit of a dimple in the anterior wall of the right ventricle, which means it collapses, it becomes concave, I know that ventricle is going to be okay, and we're not going to be on a lot of rocket fuel. But if the right ventricle stays convex, that is, it stays round during the whole cardiac cycle, which is what Dr. De Silva is talking about. When the anterior wall in the infundibulum it bulges out through the entire cardiac cycle, you know that you're going to be coming off on a lot of epinephrine, and you're going to be wondering whether anesthesia is doing acrobatics and whether you're going to have to go back on and do a bidirectional Glenn. So it would be interesting to correlate actual gross inspection of what the ventricle looks like with the MRI, because this may be helpful information. And I think, as we've said all along, with just about every congenital heart defect, earlier surgery is going to be better in the long term, within reason. But I think it really does depend. This lesion in particular does depend on a proper cardiovascular team, imagers that know how to obtain the information, interventionalist surgeons. I mean, you have to have confidence in the people that are actually doing the procedures, because we do know that patients will do pretty well for a long period of time if you leave them alone, but they likely would do better if you intervene with a good intervention earlier on.
Thank you, Joe. Very, very nice description. This is what I used to call the paralysis of the infundibulum. When I see that, my heart sinks.
Yeah.
Okay.
Maybe, Victor, there was some questions from the audience, and there are two questions actually on centralization of this splice care. So I'd like to address that. Maybe it's a good ending of this webinar. One question was that Europe's most important database for rare disease, Orphanet, mentions that there are about 165 expert centers in Europe for ebstein anomaly based on literature. However, there are only a few centers that assure follow-up of their significant ebstein patients, like GUS and Munich. And then the question is, how can we improve the situation for the patients with ebstein anomaly in the European Union? Does it make sense to set up a US, EU, or an international accreditation system for ebstein anomaly expertise center? Is that feasible? Maybe the surgeons could answer that question, because I think the surgical expertise is very important.
Well, since I'm moderating, I have that privilege. Joe, you have a go first.
Well, I would say these are the factors that I would take into consideration. First, it's a very, very uncommon anomaly. That's problem number one. When you look at congenital heart defects, this one is a very uncommon one. The second thing is that, in contrast to essentially every other congenital heart defect, every heart is different. So it becomes very difficult for cardiologists who are doing the imaging, cardiologists who are taking care of the patients from a clinical standpoint, and surgeons doing the operation to get comfortable with it, because there are slightly different nuances. There are going to be different things that you are going to do surgically. So if there was a lesion where you were going to try to consolidate centers that are going to take care of it, it would make sense for this to be a lesion to set an example for that, simply because of its rarity and the fact that everyone is different. So in contrast to tetralogy or VSD, where every time you do an echo and every time you open up the heart surgically, you are more or less going to find the same kinds of anatomic findings, which makes it easy for the surgeon to get comfortable with doing a procedure, because it more or less ends up being very predictable and reproducible. So I don't know what the right number of centers is, but I would say that it's not practical for a surgeon doing it 1 or 2 times a year. It's not fair to a cardiologist who's looking at images a half a dozen times of a year to really feel like you get comfortable with all of the nuances. And we've heard many of them today with all these amazing presentations. It's hard for people to get into a groove with it, and so it makes sense to streamline it so that the centers that do see them see a fair amount of them, that gets everybody comfortable. That would be what I would factor into the equation, and maybe Dr. De Silva wants to add to that.
I think I kind of agree with, but there's one subject that need to be worked on. That is a newborn. Newborn is we're starting the newborn nowadays, and we have to work on improving results in the newborn. And I think this is a big challenge. And I know that in some areas they do MRI in the uterus, and this could be something good to define the gravity of the case, how bad they are, and it makes sense. But I agree with Joe that you have to get the centers that have a certain number of cases per year, so we can decide better in the future what to do, what else we can do to improve the results.
May I comment on that question? I did not know there are so many Epstein centers in Europe, but in the UK, with very particular specific criteria and standardization, we have regional centers for congenital heart surgery. But for Epstein's, I go with what Joe said. It is such a rare lesion, and the morphology is almost infinite, and the critical stage is the surgery. And I would go for a smaller number of centers dealing with these very unusual problems. And one more thing, I hope Justin is listening. I think with this very alternative educational activity, bringing in so many people from more than 100 countries, it is a way of really educating a lot of people who are interested in the Epstein to understand the immense challenge behind a lot of the surgeons, a lot of the cardiologists and intensive care doctors dealing with this very difficult group of patients. Justin, thank you so much.
Thank you, Dr. Seng. And so that was a wonderful set of presentations and discussions, and we are honored to have such expertise on this webinar. So we're going to end here, but I would like to thank the panelists and moderators. I also would like to thank everyone who is listening in today who makes Heart University possible, which included approximately 800 viewers joining us today. Dr. Hang did a particularly great job following our expert surgical panelists, and we all wish her success as she starts her career at the Royal Brompton this month. Please be sure to visit our website and explore all the educational opportunities that we have to offer. And as I mentioned before, we'll be releasing our schedule for future webinars for the upcoming year soon, with the next one planned to be on pregnancy and congenital heart disease, and the following one on congenitally corrected transposition. Please also remember to complete the survey that's sent by Dr. Jonathan Windrum, editor of our ACHD Learning Center. And we wish you all, your families and patients, good health, and please reach out to us with constructive feedback. And as always, we welcome anyone interested in getting involved in this global effort. Thank you.
Thank you, Justin.
Thank you, guys.
So much.
Thank you, Justin.
Thank you all.
Very much, Justin.